All right, everybody, it's Jamie. I'm here again with Dr. Peter Steinberg, who is a urologist. You specialize in, I didn't mention this on the first episode, but specialize in vasectomies?
Sort of. So I'm actually, most of what I do is kidney stones, to be honest.
Really?
Yeah. So I'm at Beth Israel and I'm in charge of our kidney stone center.
Okay.
However, the second most common thing I deal with is vasectomies. So.
Okay. With the episode prior, we were talking about circumcisions. This episode, I want to touch on vasectomies. I feel like we're touching on two topics that people think about a lot, maybe talk about it in their homes, but may not outwardly talk about. So that's what we're talking about, and to get more information. I would love to start with the conversation around vasectomies. Can we just start with what is the history behind this? Like, why did they get started? What's the deal there?
So I'm straining my memory here. However, if memory serves me correctly, it was either in Italy or in London when the first vasectomy was done in the 19th century. So I believe there was some, no pun intended, seminal work done in dogs before. And then I can't remember. I feel like it was London where the first one was done in the 19th century, but that's sort of when it came around. There've been adaptations along the way since refining the surgical technique.
And when we're talking about what is a vasectomy? Like when we're talking about what is the actual, it is a surgery. What is the surgery? What are you doing? What is the goal?
Sure. I wish I had a prop, so I'm going to go back to using my sweatshirt. So if my body is my testicle and this is the vas deferens.
For those of you who are listening to this and not watching the video, you need to go on YouTube and watch the video.
So if this is the testicle making sperm, the vas is a skinny tube that basically goes up into your groin and down deep into your pelvis so sperm can get ejaculated out of your body. So it's a tube that runs, you can feel it in the scrotum as part of the cord that suspends the testicle. But then it goes up into your groin and down behind your prostate so the sperm can go out with the other components of semen.
And that is the site of the surgery.
And the site of the surgery is in the scrotum. If you were describing it to someone on the street, you would say it's halfway between where your scrotum joins your body and the top of your testicle is. So kind of that midway point. In between.
And what is the procedure? What are you doing when you do it?
Sure. So what you're doing there is you're trying to permanently divide that tube so sperm cannot be ejaculated out anymore.
Okay. And when you're talking about the complexity of this surgery, how complex would you say it is?
So there's the reason why it's complicated is not so much what you're actually doing, because what you're doing is, it's like, I'd say a 3 out of 10 in terms of surgical complexity.
Okay.
If one is like
the scale.
Yeah, let's say 1 out of 10 is popping a zit and 10 out of 10 is like redo heart transplant in someone who's a Jehovah's Witness or something. This is like a 3. The thing that makes it hard is most of them are done in the office and people who are awake. So you have a super captive audience. And you're taking sharp stuff like near the ball sack. And so that kind of ups it to make it tricky.
Is there anything, so when people are looking into the option of vasectomy as a form of birth control, right? Essentially. What would you say, similar to the questions that I was asking around like circumcision, what would you say are the things that you should consider in making this decision?
Sure. So vasectomy obviously is meant to be a permanent form of male sterilization. So, and the analog in women would be a tubal ligation. So when you're dealing with, if we just isolate it to male forms of birth control, you've got abstinence, which is super effective, although, variable success rates in terms of being able to stick with the plan. You got condoms. So failure rate there depends on a lot of factors, but like failure rate is, not trivial, single digits, 10%, 20% if you're dealing with like teenagers in terms of how they use them. So, and they're, they can break and you can take them off wrong and there's anything in between. So there are issues there. There's research on it, but there's no available male birth control pills. And I think that much like female birth control pills, if they did exist, people forget them, they interact with drugs, stuff happens. And then, you can pull out, which is, probably more effective than people think, but again, not sure-proof. And then there's vasectomy. So it is meant to be permanent. It usually is, and it's more effective than everything except for abstinence, including tubal. So it is the way to go for permanent sterilization if you're going to keep having sex, in my opinion, all things being equal. And highly underutilized in the United States.
And when you say, so there's this whole ideology that and people make the same argument for tubal ligation too, that it's reversible. Is it actually reversible?
So yes, but so sure. I mean, you can reverse a vasectomy. However, anytime you start tweaking stuff, there's no guarantee it's ever going to work the way it did before. So it used to be when in vitro fertilization was not covered by insurance as much and not as mature as it is now, that vasectomy reversals were much more popular to try to deal with fertility issues. Now, especially around here, I mean, people I see for vasectomies are often in their 40s or 50s or 60. And so a lot of times, you know, reversing it isn't even in the cards. You're just going straight to IVF for a lot of people. Okay. So yeah, they are reversible. However, the success rate of that depends on a lot of factors. And one of the biggest ones is how long it's been since you had the vasectomy. And the other one is, you know, who's your partner? So even if you have a vasectomy and you go to reverse it a year later, there's no guarantee you're going to have success in ejaculating live sperm again. And there's also no guarantee of fertility again. So if you're in any way considering any future fertility, I highly advise people not to have a vasectomy. Okay. You can surmount all those things. It's just, it's more complicated.
Right. When you're talking about so things that we were talking about, obviously, like things that you should consider when you're considering getting a vasectomy. What about risks and benefits?
Sure. So
we touched on the benefits. Yeah. What about risks?
So big things to think about. So if you're considering a vasectomy, you know, number one is, am I done having children or not want to have kids? And certainly we see people who want to have no children. Right. So that's number one. So number two is, you know, what is your current birth control situation? A lot of times we're seeing people where IUDs are coming up for expiration. Yeah. There's a problem with pills. Yeah. There is some medical issue all of a sudden and you can't be on this, or your wife is reacting badly to her birth control. It's interfering with the medical, whatever. There's some other issue with the birth control plan a lot of times. Yeah. So that's often why we're doing it. And there's no good female solution. Right. You know, another big part of it is a lot of people are weighing tubal ligation versus vasectomy. Right. It's one thing if you're going to have an elective C-section and they're staring at your tubes and
you signed a consent ahead of time.
Yeah, you know, all right, fine. However, all things being equal, a vasectomy is more successful, so the failure rate is way lower. So tubals fail, and there's no way to tell a tubal worked. Like the only way you know is you just didn't have more pregnancies. Right. If you do a vasectomy, we can check your sperm count, and if it's 0, there is a small but very small chance of a failure after that. Yeah. So you know if it's going to work or not. And tubals kind of like, I mean, it usually works, don't get me wrong, but they're failures. So the vasectomy failure rate is reported to be 4 times lower than the tubal failure rate.
Wow.
Yeah, it's a huge difference. Yeah, huge difference. The other thing is, you know, a tubal is intra-abdominal. Yeah. There are potentially life-threatening risks of tubal ligation, like bowel injury and stuff like that, which, I mean, they happen. And, you know, vasectomy is usually an office procedure, half an hour, peas on your scrotum the next day. You know, it's a way different deal and highly underutilized, like I mentioned a minute ago. Yeah. So, you know, if you're weighing those two things, unless you're dealing with some male reason why it's a bad idea, like serious prior scrotal problems, you know, chronic scrotal pain, major anatomic problem, major bleeding problem, which are rare. Right. Really, for the most part, vasectomy should win out over tubal in most circumstances.
I mean, and win out over, I mean, this is going to sound biased, but like truly talking from like an effective birth control standpoint, like actually win out over over just a form of effective birth control.
Yeah, and I'm not,
even if you're talking about the, you know, the failure rate of condoms, of oral birth control. IUDs pretty actually reliable.
Pretty reliable, but still have a failure rate.
Right, and you don't know if it's out of place until you find out it's out of place.
Right, and they can perforate your uterus, and you know, they can end up in your wherever. Yeah, strange things happen.
But I mean, correct me if I'm wrong, I guess is my question. Like, it sounds like it is actually like a low risk but very effective form of birth control.
Yes. The only issue is it's permanent or meant to be permanent. Right. That's the issue.
That's really what you need to consider.
That's the issue, is it's meant to be permanent. But if you're up for permanent contraception, it's the way to go. And it's more effective than everything but abstinence.
Okay. It's more effective than everything but abstinence. That is the soundbite for this. Walk me through the procedure. Walk me through, like, somebody comes in, how are you making the decision? is there a time how you make the decision between a local anesthetic
Sure.
and putting somebody to sleep? And then actually walk me through the procedure and recovery.
Sure. So, different urologists deal with this differently. In most vasectomies in the US are done by urologists,
Yep.
and in this area, almost all.
Yep.
Some people will see people the same day that they'll do the procedure. I personally don't. I have colleagues who do that. And there are a variety of different reasons that people do that. And sometimes people change their mind or logistics, whatever, but both are reasonable.
Yep.
So, and you may want to find out ahead of time if that's the deal, because if you're seeing someone who's not going to do it the same day, you don't want to be surprised.
Right.
Likewise, if somebody's like, hey, we're doing this now, you got to make sure like someone can drive you home and stuff. So, there could be a little variation there. The main thing the urologist is going to look for in that consult is your scrotum okay to do it in the office? Or do you have like super tight, tiny scrotum and you need it under anesthesia in the operating room?
Okay.
Or if you had like a hernia repair or surgery on your testicle or something, and it's going to be hard to do awake. So that's what we're looking for.
Okay.
If they want to see you ahead of time.
Okay.
Some people will honestly even have somebody else set everything up and just show up for the procedure. I personally think it's risky because you can just cancel while somebody's like got their cleaned up, prepped, shaved balls for you. But I like to not have those surprises. But some urologists even do that. But that's what we're looking for. Any red flags in your history, bleeding problems, are you on blood thinners, anesthesia problems? But can we do it in the office? That's basically what we're looking at. So procedure itself, usually about half an hour.
Can I ask one
Sure. Yeah.
question
Sorry.
Before we move into the procedure?
Yep.
What if you have somebody, like you said, like it's an interesting procedure in the sense of like you have somebody who's awake under local anesthesia, and it's a captive audience. Is there a scenario where you do use general anesthesia or other medications for somebody who's like very anxious or can't sit still?
Sure.
Or,
Good question. So everyone's got a different threshold for this. So I had a partner who had been in the Air Force before and did a gajillion of these. He had a low threshold for doing them in the operating room. My threshold is probably a little more in the middle. So I'd say I do about 10% a year in the OR.
Okay.
And those are people who prior surgery is going to make it hard, or they're turning white when we're playing the video. So you could just palpate the anxiety, you know. And I never talk anybody into doing it in the office. So if there's any doubt, we put them to sleep.
Gotcha.
Other people's threshold may vary.
And I want to be clear, there's risk to putting somebody to sleep.
Yeah,
which is what we're trying to avoid those risks if
yeah.
possible.
I mean, it's not, it's not super duper risky.
Right.
However, if you can avoid it,
Right.
it makes everything easier because it's quicker from a scheduling standpoint. It's easier. You don't have to fast. You know, all that stuff is just easier.
Right.
You walk in, you walk out. So all that being said, office, different people do different things. I give people oral Valium.
Okay.
So unless they refuse it, so that they're relaxed.
Yeah.
I have some colleagues who use inhaled nitrous oxide. You know, there's a little hookah they can give people now, as opposed to the dental thing. So I haven't personally done that. I think the Valium thing works well. But that's an option. And some people will have other sedation options in the office. But many people won't do any of that, and they'll just do like warm towel and relaxing music. So everybody does it differently. But some anxiolysis could be part of it. And that's definitely something worth asking about. Because different people have different setups in their office for what they can offer.
Love that.
Yeah, but honestly, if there's a huge degree of anxiety, my opinion is that should be done in an operating room or with, office sedation with an anesthesiologist or someone like that, so you're not aware of what's happening. Because it's just a struggle for everybody then. It makes it like actually really difficult if you're fighting. That's a nightmare. So, so procedure itself usually about 30 minutes. There are as many ways of actually dividing the vas as there are urologists. So different people do different techniques. A lot of the questions I get are about something called a no scalpel technique versus scalpel versus other. That's a fancy way of saying the no scalpel technique was invented by a guy in China 50 years ago that basically involves grabbing the vas, numbing it up, and then making a hole in the skin with a sharp pointy device instead of a scalpel.
Got it.
It does have some improvement in the bleeding risk compared to using a scalpel, but it's not a huge deal. So people who are like, oh, I'm having a no scalpel vasectomy. I want a no scalpel vasectomy. Fine, knock yourself out. But it's personally not how I do it. But a lot of people use that technique. But it's nothing magic. All right. It's the same.
Not huge differences in terms of outcome.
The surgery is basically the same. Very small difference in the bleeding and bruising rate. So, and in my opinion, it's not enough for me to have changed my technique.
Right.
And many urologists feel the same way.
Okay.
What you don't want is someone who's going to make a humongous incision in your scrotum. So you want someone who's, if they're going to use a scalpel, to make a small incision.
And how big are we talking the incision?
Centimeter. So you're
Right.
talking like very, very small.
Right.
And then basically what the procedure involves is freeing this thing up. It looks like a piece of spaghetti, and then dividing it in a way where the ends won't grow back together. And there are many, many, many techniques for using that.
Okay.
That's a super inside baseball thing. You can ask your urologist what he or she does.
Based on like who trained you?
Probably. Mostly.
Okay.
Yeah, I'm like a mashup of people who taught me how to do this.
Yeah.
And I've made some tweaks over time. And there's some suggested techniques that are more successful than others. But the bottom line is the guidelines the American Urologic Association has says if your technique works, just keep using it.
Okay. And then that incision that you're making, suture it up.
So it depends. So with the no scalpel technique, a lot of times they just leave it open.
Nothing.
Personally, I use Dermabond tissue superglue if the skin edges aren't bleeding a lot, because usually the stitch holes would bleed more than the incision.
Okay.
Some people close all of them with dissolvable sutures.
Okay.
We always use dissolvable stitches on the penis and scrotum because you don't want scissors coming back at that,
Right.
you know?
Yep, that's fair.
So usually pretty quickly dissolving, like within 5-7 days, like chromic usually. And some, it's everything between leave them open, put goop on them like bacitracin, Dermabond, or sew it up.
And anything that you warn people about prior to the procedure or during the procedure. So for example,
Sure.
I feel like the thing that I have heard most is there's a smell.
Yeah.
At some point during this procedure, there's a smell.
Yeah.
What's the deal with the smell?
Sure.
What do you warn people of?
Yeah. So I'll tell you what I warn people about. So I actually, I see so many people for this. I got sick of saying the same thing over and over. I made a video that the medical assistant puts the patient in the room and they watch the video. It's like 7 minutes long. It's on Vimeo. You can just look up Vimeo vasectomy Pete Steinberg. It's out there. So the 2 or 3 big things I warn people about. So number one, when you numb the vas up at the beginning, everyone should use local anesthesia for this. Some people grab it with some type of gizmo and then numb it up, which hurts a lot. You may want to ask your urologist what he or she will do. Some people grab it and numb it up and then wait and then grab it with a gizmo. So that part will hurt, either getting it anesthetized or clamped and then anesthetized. And so in the video I made, I describe it as getting kicked in the balls and stung by a bee at the same time. So, and some people do it through one incision, some 2. So it could be both sides. But basically what most people are going to feel is the needle putting local anesthesia in your scrotum, but either sensation in your testicle or up in your stomach or groin, like you've been kicked. So all guys will know what that feels like, but they'll feel that. And they'll get numb pretty quick. So they'll feel that, and that's important to know. And we don't want people jumping because we got a needle by your scrotum. You don't want to get stuck. Then the other part is the tugging, pulling, sensation of touch. None of that is going away. It's just the pain that's going to be blocked during the surgery. So people will say like, "Oh, I feel you touching me. I feel you pulling. I feel pressure." Like that's going to happen. It's not spinal anesthesia. It's just it's just knocking out the pain fibers. So so people will feel that. You're going to feel tugging, pulling. Sometimes the pulling will make people feel like they're going to throw up or pass out. Scream for the nurse, get the sick rag. Trendellen, but that happens. And then everything's fine 2 minutes later. But then when we do go to divide the vas, a lot of people use a cautery device to use heat energy to divide it, so it won't grow back together, and that'll smell like burning hair. So I will say you're going to smell smoke. I always say you're not on fire, I promise. But both sides, and we try to evacuate it with a sucker, but you still smell it. So, but it smells like burning hair if you've smelled that before. So, or barbecue. So
just all the things
FYI,
all the things you want to smell when you have a provider with their hand on your scrotum.
For sure. And if you're in an office where they're using like a machine to generate the cautery current, it'll make a noise when they're about to use it. If you're using like a little battery operated eye cautery, which a lot of people use, that won't. You'll just all of a sudden, smell the smoke. But less smoke is generated by that gizmo.
And recovery. What do you tell people in terms of what to do for recovery? Ice, medications, things like that. And how long is the recovery, the physical recovery?
So this is super critical. So people who are not active, this is not a big deal to get better. Or couch potatoes, no problem. The issue is people who are active. So bike riders, lifting, run, whatever, any of that stuff. And it's tough because everybody's got little kids usually who want a vasectomy. My advice is take it easy for 10 to 14 days. What I really urge people is the first few days after the procedure, avoid heavy lifting. So like if your kid's about to die and get hit by a car, move your kid. However,
somebody else pull them out of
yes, to the extent you can get help with lifting kids, all that stuff for those first few days, it's really critical. If you can get a week, it's great. If it's 10 to 14 days or your kids can walk, even better. Okay. No bike riding for a week minimum. You know, and the big thing I tell people is if you do a manual job, you need a week off. Construction, police, military, minimum of a week. Okay. Desk job, you can be back to work, you know, a day or two later, no problem. But any lifting, you know, you need the like some time up front, and if you're fine, then you'll be good to go. Yeah. If people push it, then you have like a 3-month recovery. Yeah. So I really try to tell people, try to take it easy for 10 to 14 days. It's really the first few days and first week that are most critical. Okay. Really important also, like ice on and off of your scrotum first day or two. Frozen peas, corn, deformable, whatever. Yeah. Supportive underwear, boxer briefs, stuff like that. You don't need a jock strap, just something that's tight. You don't want your boys swinging around. Right. And that's most of it. Tylenol, Advil, yeah. One other both is usually all people need. I'd say I give some opiates out once a year, maybe. Okay. A couple for somebody who's really struggling, but that's pretty unusual. Okay.
And then complications.
Sure. One other thing about recovery, so it's important to know, is you're actually not immediately sterile after you're going to get to this later? All right, we'll get to it later. All right, good. Many we'll hold it off. All right, very good. Okay. So complications? Okay. Yeah. Biggest risk, bleeding, bruising, swelling. Yep. So, and you know, the skin incisions can bleed. That can usually be fixed in the ER or the office with a stitch if that's happening. We worry about scrotal bleeding. Yeah. So the scrotum can hold a ton of blood. Yeah. So most of that can be prevented with appropriate surgical technique. Okay. There's an artery that supplies the vas that we're very careful to deal with during the procedure, but you can get bleeding from anywhere in the scrotum. So avoiding strenuous activity, icing, heavy lifting, that helps reduce that risk. And that's why that's so critical, because that can take weeks to get better, or months sometimes if it's really big. So we really want to avoid that. Infections, super uncommon. You know, oral antibiotics usually deal with it. That's rare. One thing that can happen that is uncommon, although probably not as uncommon as we think, is getting chronic pain in the scrotum or testicle or surgical site
following the surgery,
following the vasectomy. So it's not super well studied. What's out there would suggest the rate, and it's suggested to counsel people, the rate is 1 in 100 men will get chronic pain. Most of that is probably post-op that will still get better. However, sometimes it's hard to predict who's going to have an issue. I would say if you have any chronic pain conditions, you need to tell your doctor. And that's probably a reason not to consider the surgery, to be honest, especially if you have any chronic scrotal problems. But that can happen. And so if you're having pain outside of the 2, 3, 4 week post-op mark, it's important to call your urologist and start to figure out what's going on, because usually we can arrest that or mitigate that. But there are some men out there with chronic scrotal problems that started with a vasectomy. Occasionally, it's bad enough to need the vasectomy reversed, actually, to try to improve things. So that is important to know. It is probably rarer than 1%, but that's generally the rate we quote people.
Okay. Let's go into what you're about to go into related to the recovery and not being sterile right away.
Sure.
So following a vasectomy, men are told to ejaculate a certain number of times before the protocol here is, as I understand it, ejaculate a certain number of times. What is the number?
It depends.
Okay.
So everyone ejaculates at a different efficiency.
Okay.
So basically what we're looking for is you want the sperm count to either be 0 to clear people for not using birth control.
Okay.
Or for the count to be so low and all the sperm are dead that the chance of a pregnancy is exceedingly low.
Okay.
In most men, you are looking at 10 to 20 ejaculations. Okay. Most people put a time on it, not an ejaculation number.
Okay.
Because often we're dealing with people with young kids. Who knows how often they're actually ejaculating. So I would say nowadays, most urologists, you're looking in the 6 to 12 week window to do that test.
Okay.
If you've ejaculated twice, do not do your post-vasectomy semen analysis. It will still have sperm. So, but you probably need a low double-digit number to clear.
Can you talk about the semen versus sperm?
Yes. So, so most of what comes out when guys ejaculate is not sperm.
Right.
Sperm is probably 10%.
Right.
90% is semen made by the seminal vesicles. It's a big grape-looking shaped gland that sits behind the prostate. That's not touched. So in almost all men, your ejaculate volume does not change unless you're like micropipetting your jizz and you know exactly how much comes out, and in which case you need to see somebody else. So most men, it's way, So most men will not notice a change in ejaculate volume after vasectomy. Sometimes they do. Very, very unusual though.
Yeah. So vasectomy is only addressing sperm and sperm count.
Only sperm, not semen production, and it shouldn't, once you're recovered, affect your satisfaction, desire, erections, whatever.
Right. Okay, so following the procedure, more timeline than actual number of ejaculations in terms of having your follow-up appointment.
Generally speaking,
At that follow-up appointment, generally speaking, you are providing a sperm sample. And your count, and there's a test that you do to count the amount of sperm.
So there's different ways of doing this. Some people have people come in the office, which creepy, to produce the sample. We don't actually run these at our hospital. We send them out.
Okay.
So the way we do it, we give you a couple labeled specimen cups at the procedure, tell you to produce the sample about 6 to 8 weeks later, and then drop it off at the lab. But everybody's going to have a different deal. Some urologists are going to look under the microscope themselves. Some are going to work with a fertility lab. Some it's the hospital lab, whatever. But you get the sample, they check it, and what they're looking for is, are there sperm? Yes or no? If there are sperm there, are they alive or dead? And then what's the count?
Okay.
So if you have no sperm, you are cleared to stop using birth control.
Okay.
If there are sperm, if they are alive, that would suggest the procedure did not work, and it probably needs to be repeated.
Okay.
Most likely under anesthesia. Because either you have two vas on one side, it wasn't correctly divided, you divided the same side twice and didn't get one side, which can happen.
Gotcha.
It grew back together, whatever. So, and certainly if you have a normal sperm count with live sperm, it definitely did not work.
Okay.
So if you have a low count of dead sperm, you may get what's called special clearance to stop birth control. Some urologists may still have you give another sample a month or two later. So it depends.
Okay.
And it depends on how the lab that you're using reports it out.
Okay.
But you may need to give another sample before you're cleared if the first one is anomalous.
How often does it not work the first time?
So in terms of getting a straight up fail where it needs to be redone, you're probably looking at about 1% or less of the time.
Okay.
So it should be a pretty infrequent occurrence where you're just coming back and you have a normal sperm count. So does happen, not that common.
Okay.
What's more common is there are still sperm. You need to go ejaculate more and come back.
Gotcha. And how important would you say that follow-up appointment is?
So, well, the reality is a lot of people don't do it. So it's funny. I got a call from somebody about something unrelated about someone, and I looked back in this guy's chart and was like, oh, this guy never did this. And that happens a lot. So, you're probably talking 25 to 50% of men don't bother.
Okay.
I actually had one of my attendings in residency who had a vasectomy. And I was like, did you ever do the sperm test? He's like, nah, I figured it just whatever. I'm like, what the hell?
Chances are my favor that it works.
Like, what? So he's like, yeah, I think his exact quote was, it's God's will if I have another kid. So at any rate, but a lot of men don't. And I think they just figure, oh, well, if I didn't have another child, that explained it. That would not be my advice. I would suggest you follow through to make sure it worked. There is a test you can do at home called Sperm Check. You can get it on Amazon. It's an over-the-counter thing, actually. The issue is it's designed for infertility testing.
Right.
Its cutoff is higher than the cutoff we would suggest for being specially cleared.
Okay.
And the other issue is it doesn't tell you if the sperm are dead or alive. It just is a count. So some people have done some work saying if you do 2 of those, you are probably fine mathematically. However, that's not what the guidelines would say, and that's not what I would suggest.
Okay. Similar question to what I asked you when we were talking about circumcisions is when you're looking into a doctor, whether that's for a circumcision or a vasectomy, what would you say are good things to ask or look into in terms of obviously like experience, how long you've been doing it? I think similar, most doctors are probably not going to know exactly how many they've done. What things would you say ask about when you're researching this?
Sure. I can say this with like almost 100% conviction. Every urologist in practice has the same story of doing his or her first few vasectomies in practice. They are all a shit show. They all require getting a more experienced person to come help you. I was no exception. Luckily, the statute of limitations is long expired on those first couple of events early in my career. Do not have someone who's in. I mean, obviously, everybody has the first whatever. Always have. Do not go to someone who just started in practice unless that person is a infertility, men's health trained provider who has extra expertise in doing this.
Okay.
All urologists in residency learn how to do vasectomies.
Yep.
Most think it's kind of a joker thing because it's in the office and they want to do big whack, kidney cancer surgery, and they think it's a joke, and then none of them can do it.
Yeah.
And I was no exception. So you want someone with experience.
Yeah.
And it doesn't need to be a ton of experience. So someone who's been out in practice for a year or two, unless that person's done subspecialty training, you're going to probably be just fine.
Okay.
I would say in terms of a number, we actually looked this up the other day, like what's a high volume? It's actually not that many.
Yeah.
But if you're dealing with someone who's doing, 1 or 2 a month, you're already dealing with someone who's relatively high volume.
That's good to know.
Yeah. And someone who's doing, 1 a week, I mean, that's probably in the highest quartile in the country, to be honest.
Gotcha.
I mean, there are people who do hundreds and hundreds and hundreds a year.
Okay.
But if you're dealing with someone who's doing a vasectomy a week, that person is doing a ton.
Okay.
And you're going to be in
That's
good shape.
good to know.
You just
Because
don't
I feel like from a general standpoint, you'd be like once a week or 1 or 2 a month, like doesn't sound like a lot.
No, but that's a lot.
That's a lot.
Yeah, especially been in practice for a few years. That's
Right.
Hundreds and hundreds or
Right,
thousands.
Right.
So just avoid that person who's just fresh because it's just not going to go well.
And it sounds like based on what you have.
No offense to the new urologist.
Yeah.
I was once one.
Yeah. It sounds like based on what you said so far, asking specifically, like asking more generally about the procedure is good. Obviously having a good understanding about it, especially depending on like your level of anxiety going into it. But it sounds like knowing like more specifically about the actual procedure and how they do it is going to vary so much from doctor to doctor that it actually does it really matter like what sort of technique they use? More from a it being successful and or having complications standpoint.
I mean, do you ask the pilot how he flies the plane or she? I mean, yeah. So look, I mean, if you want to get micro into that, that's fine. I think if you're dealing with someone who does a decent number and they're honest and they haven't had a gajillion lawsuits and whatever, I just personally, I'm just getting into the questions of micromanaging how a surgeon actually does something. As a layperson, you can research. It's just not generally helpful.
Well, and it sounds like there's many different correct ways to do this.
It's all silly pants, if you ask me, trying to get into, do you do this? Do you do, I mean, if you want to do that and that's how you want to pick your person, that's fine.
Okay.
I just think that
it's more so about experience.
Yes.
You like the person.
The urologists I know who've had vasectomies, they go to the person in the group who does the most of them. And they don't ask all these questions how they do it. They're just like, who does the most vasectomies in our group?
Nobody's suing you and they seem to work.
Right. And if you want to ask all the questions, it's fun to talk about, but as a patient, it doesn't matter. You care that you don't have a complication and you get sterile.
Yeah.
Boom.
Great. Yep. Awesome. Anything that you would add that we haven't talked about?
Let me think.
Questions that you get asked or
The American Urologic Association has publicly available guidelines on the procedure that are out there. That you can just look it up. AUA vasectomy guidelines. You can read the whole document. It's got a gajillion references. Most of it is applicable to urologists, but you can sift through it. The main thing to know, in the old days, they used to be worried vasectomy was associated with other health conditions. That's not a concern anymore. They used to be concerned about things like dementia, prostate cancer, stroke, cardiovascular disease. It's explicitly in our guideline statement. You don't need to talk about any of that counseling anybody. So affiliated health stuff, you don't have to worry about. That used to be a thing people used to worry about a lot. The other big thing I would say is it's just very heavily underutilized in terms of birth control in the US. I personally feel like it's important that men consider this to reduce the risk, A, of pregnancies because Tubal is less effective, but B, the potentially serious complications. And it's one thing if you're having an elective C-section, I totally get it. I understand that. But if you're, having a kid and then the next day you're having your postpartum tubal, when your partner should strongly consider a vasectomy unless there's some major contraindication. It hasn't been pushed heavily enough by the public health people in the US, but it's an important message to hear.
I love that. I'll link some of the resources that you mentioned, including your Vimeo video.
Yes, that'd be great.
For people going to have their vasectomy.
Yes, and bring something to listen to. Bring your AirPods or whatever. And I strongly urge podcasts, not music or a book. You do not want to associate a song with your vasectomy. So that's just the
birth of your child, not a vasectomy.
That's right. That's just my last piece of advice on that.
I love that. Yep. Well, thanks so much again.
You're welcome.
And hope you all found this entertaining and informative.
All right.
All right. Thanks so much.